My talk's going to be on medical aid in conflict zones. I think everybody already knows I'm Mohammed. I'm a third year. Um, Special thanks to the disaster team, Dr. Silverberg, Dukas, Daniel, Dr. Levitt, Dr. Barrios, and of course, our research chief, Dr. Davila Esteban. So why is this topic relevant? A lot of us will be asking. We're not in a crisis zone right now, thank God. So why is it relevant? Number one, this is a disaster series, so it's relevant. But secondly, we're in a different age now, right? We're in an age of globalized news, independent journalism, stuff travels, and whereas at one stage in history we kind of didn't know what was happening in other parts of the world, now we're kind of in a different, stage where we do know when things are happening, and so that can create a sense of before even a call to action, just a sense of a little bit of anxiety, a little bit of a desire to think about what can I do, especially as EM docs, who basically our mantra is, if you can do it, just do it. That's the first thing. The second thing is those of us who will kind of go down the path, as some of our alumni have, of going into medical relief work, will kind of, at this stage, at least in our training, be asking a lot of reasonable questions like, how helpful is an emergency physician in a conflict zone? Aren't conflict zones more for like surgeons and anesthesiologists? Are emergency physicians even allowed in conflict zones? Don't you have to be affiliated with like the armed forces or something like that to get there? And so these are a lot of reasonable questions. And so hopefully in this talk, we'll just unpack what is the role of an emergency physician in a crisis zone, kind of the intersection of disaster medicine and global health, and hopefully we'll just dispel some of the misconceptions and make this more tangible. So the first thing is understanding why medical aid has become such a major thing in this day and age, actually, especially for emergency physicians. And it's because of this concept called hybrid warfare. So whereas, back in the days, the good old days, you'd watch these movies of like the Romans and the Persians, and you'd see people lined up in ranks and they charge at each other. That's not how war is anymore, as we know. Now there's this concept of hybrid warfare, which is taught in most military and like the armed forces, and it's a very, if you just do a quick Google search, you see a lot of discussion about this topic, and it's very well accepted. It's basically the idea that the best way to kind of address a disagreement through war would be to not just target the military of an opposing enemy force, but also the institutions and support systems. And so we know this, everything from sanctions to pressuring, which would be financial, to pressuring them in terms of their even civil mechanisms, right? And the worst of it would be attacking healthcare infrastructure. And we've seen a lot of that recently, just in the past like 20 to 30 years especially. And is it that we're seeing more of it, or is it that because more of it's happening, or is it that we're seeing more of it because we have the access to see it because now we have social media? And who knows, honestly, but we are seeing more of it. Now, you guys are probably familiar with the Geneva Conventions of 1949. So this was basically after the Second World War, a bunch of people got together and said, well, that was pretty terrible. So let's think about a way to make that less terrible. There's probably still going to be wars in the future, but maybe we should have some like rules around it so you don't just kind of do whatever and hope for the best. And so they came up with the Geneva Convention of 1949, which were actually adopted in 1950. But these were supposed to be like the rules that were supposed to govern the impacts of war on civilian population. They were supposed to, this is what we call modern day international humanitarian law. And they spoke a good deal about actually healthcare and the impacts of war on healthcare and the limitations and the restrictions. And interestingly enough, they felt the need to explicitly talk about hospitals. And as we'll come to see, in hospitals, the most vulnerable areas are actually the emergency departments. And you're probably thinking like, okay, great. So we're vulnerable to like infectious disease already. We're already vulnerable to like, violent patients and violent family members. And now we're vulnerable to war. Yeah, we are, unfortunately. And in the ER, we're pretty much vulnerable to everything because we're first line. But this is actually a really big area of discussion and study and research, and we'll get into that a little bit. But hopefully by now you're realizing, okay, maybe this is pertinent to emergency medicine. So this is just a picture of the like an old document. But the point here is just that it was such a real prevalent issue that they felt the need to include this in the Geneva Conventions. And specifically, it was an article, it's in the second part of it, but I just took two very small snippets out of it just to kind of drive this point home. Article 18 is the one that is the most explicit on this, and it's longer than this, but this is how it starts. Civilian hospitals organized to give care to the wounded and sick, the infirm and maternity cases may in no circumstances be the object of attack, but shall at all times be respected and protected by the parties to conflict. So it's pretty straightforward, but obviously this isn't what ends up happening a lot of the times. But it is something for us to be aware of, because a lot of us may be thinking, well, you're kind of going rogue by going, there's like, if you go with like Doctors Without Borders or MSF, which is MSF, or other organizations, Physicians for Humanitarian Aid, and so many more, Humanity Auxilium, there's a ton of them. Aren't you kind of like, going into like some chaotic situation? You might be, but there are at least there's supposed to be mechanisms to facilitate medical aid in these situations, and we're going to talk about those mechanisms. This is just further explaining the previous point. So, like some examples. So, in the Syrian civil war, I don't know if anybody follows international politics, but the Syrian civil war basically came to almost a conclusion basically in December of 2024, this year. So it lasted a total of 13 years. In 13 years, 949 medical personnel were killed. 280 of them were physicians. So actually the largest percent of them were physicians, which is alarming because you would think it would be like, we don't want anybody, right? But you'd think it would be like EMS, people who are like in the field, but actually physicians were 29.5% of those killed. They were the highest percentage, despite the fact that they're in the hospital, they're not outside. And so that's why this is real. The current, war in Gaza, it's been 12 months. Well, it's been really 18 months, but from October 2023 to September of 2024, so just about 12 months and a half. By that time, 1,151 health workers were killed. Again, the majority of them being physicians and EMS personnel. They didn't like stratify the numbers enough to know how many were physicians and how much were EMS, but they were physicians and EMS were the bulk of them. And that's like in a 12-month period. So this is getting like more and more real. The Office for Coordination of Humanitarian Affairs said that 2024, this past year, was the deadliest year on record for humanitarian aid workers and for healthcare workers. So this is definitely something that is becoming more and more pertinent. And there are people, I mean, we had Dr. Lee, we had Bing, basically, who was one of our alumni, for those who don't know, come and talk to us about her various trips to different conflict zones. And so there is a role for emergency medicine. I don't mean to like terrify all of us by giving these statistics, but it's just to say that there is a role. It's not like, oh, they have their own doctors, they can figure it out. Like there is a role for those of us who would like to go and help. And then, okay, you may be thinking, well, okay, that's healthcare, but I'm an ER doctor. Like, how does this affect ER specifically? Just in April of this year, just last month, the last standing emergency department in northern Gaza was shelled and is completely out of service now. And that's, again, a situation in which this is the final incident where the emergency department is out. And in these situations, the emergency department, as we know, even here, but even more so in conflict zones, is really the entry point of the hospital, not just for like acute trauma, it's for everything. And a lot of these war zones, the emergency department will even turn into kind of like a shelter. You'll even have civilians just staking it out in the emergency department because it's just safer to be in the emergency department, presumably. And so ER, emergency medicine, emergency departments, healthcare, this is all pertinent to us, right? Is everybody, you may be asking what's the point? Like, is everybody gonna go into a war zone and try to do some medical aid? No, obviously not. But it's a disaster medicine series, and some of us may go down that path and want to participate in medical relief work in crisis zones and conflict zones. So at minimum, we want to be just aware, and the best case scenario is for anybody interested in this kind of a thing to have some education on the different avenues, the different resources, and the actual roles of an ER physician in a conflict zone. So the big picture, there are three phases of impact of a crisis or really a conflict on healthcare in a conflict zone or a war zone. The first phase is the emergency phase. So this is the most dangerous. A lot of organizations, if you want to go with like MSF, which is Doctors Without Borders, or Humanitarian Auxilium, and many others, they'll put restrictions on the emergency phase where like not everybody will be able to get in. So if you're like, hey, I'm an ER physician, I'm board certified, and I want to go, and I have this block of time, and a lot of them will still put restrictions in this phase, which is the emergency phase. This is the phase where there's active fighting, there's civil strife. But still, some organizations will take you along, but they tend to be organizations where you need to really be like staffed with them. So these are like the most prominent of them would be like Doctors Without Borders. So if you like hit up Doctors Without Borders and you're like, hey, there's like a war in this area, I know you guys are active there, and I would love to go help. What you'll get is no, because we only send staffed members to these emergency situations. We don't do like short-term kind of commitments. You have to be staffed with us, be an employee. You do a 6-month period where we send you somewhere else that's safer. And then if there's an emergency situation, you may be part of the group that goes. So it's very different in the emergency phase. The transition phase is a little bit different. It's a little bit more lax. More organizations will be willing to take you on as an emergency physicians board certified, even if you don't have like a fellowship or anything. You don't really need a fellowship. But if you're just board certified and interested, the transition phase, which is the immediate aftermath of the cessation of fighting, when there's like an official declaration that there's like no longer an active war, there's some kind of a truce. This is when a lot of not just medical aid, but humanitarian aid will start flocking to the site, including medical aid. And then the development phase is a kind of the part where you start rebuilding. So it's the rebuilding of the healthcare infrastructure, and then every other aspect of the society. So this is the phase where it's probably the easiest to get into these conflict zones. You probably don't even need to be a part of an organization. You could probably just go kind of on your own. Usually borders have opened up by this time in the development phase, and it's kind of easy to just show up and be like, hey, I have a few weeks, like you guys need any help, and you can kind of just tag along with somebody. But you wouldn't really be a medical relief worker per se. You'd just kind of be going there to volunteer your time and effort. But really what we're going to be looking at mainly the transition phase, because that's when, and the emergency phase. I mean, for anybody who is interested in being like full-time doing this, then emergency phase would also be like accessible to you. But transition phase is the most common, where like physicians who are not permanently staffed with like a humanitarian aid organizations will still be able to go and come back. So what exactly will you end up doing there as an ER physician if you choose to go? The first thing is this beautiful quote I read from one of the papers. Emergency physicians are uniquely suited to provide care in crises as a result of their board training, ability to work quickly and effectively in high pressure, austere settings, and their inherent flexibility. And this goes without saying. I mean, we know it. We do it every single day. There's just a flexibility with being in emergency medicine that renders itself, that just makes us really helpful in situations where you need to be flexible, because you can't have the OR set up the way you want to, right? How many of us walked into a patient room and were like, this is unbelievable. The thing is not set up, suction's not connected, I'm not doing this, right? No, we just grab the suction, we connect it, right? That's what we do. So we're just a specialty that's very conducive to being flexible and dealing, of course, in high pressure, stressful situations. That goes without saying. So the first rule for us to remember, do no harm. And this came from me reviewing the medical relief effort for the Haiti earthquake of 2010. Why do no harm? Obviously, that's just like a principle of medicine. But why is it pertinent to the earthquake in Haiti? Because in 2010, during the, when in the aftermath, the immediate aftermath of that massive earthquake in Haiti, a lot of medical staff flocked to Haiti from all over the world, especially from the US, just because of proximity, but really from all over the world, US, Europe, Asia. Everybody kind of flocked to Haiti. And a lot of it was helpful, but then there were a lot of issues that happened because of that. And there was a task force called the Interagency Standing Committee. So it's like it's a forum of UN groups, humanitarian aid organizations, NGOs, the Red Cross and Red Crescent. It was a whole bunch of organizations coming together saying, let's just debrief what the hell just happened, because it really got to a point where it got kind of out of control. There were just physicians and nurses and people just crawling everywhere. Some people didn't even know what to do. Some people weren't even affiliated with a humanitarian organization. There was really poorly defined roles. And there was great benefit, of course, because they needed aid workers to come, but there were also a lot of problems, and they used it as like a learning point, or like a checkpoint, kind of in the greater development of this field. So they have this long task force thing. It's like over 100 pages, this like long report. But I'll just take a snippet of it here. They cited that the major shortcomings in the medical relief effort were because of inexperience of many of the responding foreign medical workers and physicians, specifically in humanitarian and UN-based coordination methods. So they weren't a part of any sort of like process. It was just kind of like showing up with your bag and being like, "Hey, I'm a doctor, I'm board certified, and I'd like to help." Which we said is great in the development phase, but kind of in the transition phase when there's like chaos and destruction, that's really stressful for the local healthcare staff to accommodate you, because they're just kind of like, okay, do you have a plan, or are you just gonna like, and then you just end up doing your own thing and it just causes chaos. So two major examples they cited, not to hate on surgery, this is just what they cited. So, we love our fellow surgeons, but they mentioned that one major issue was because obviously in an earthquake, there's a lot of orthopedic injury. So a lot of orthopedic surgeons flocked, right, as they should, right, to help. But a lot of the surgeons kind of came on their own, and they didn't coordinate with anesthesiologists. There was no sort of like PACU set up or anything. Surgeons just kind of showed up and were like, "Hey, we'll do the surgeries." And surgeries started happening left and right, but they didn't realize they didn't have enough anesthesia. A lot of these surgeries were done without anesthesia. The surgeons weren't well versed enough in like what we would call procedural sedation, even if you can't do anesthesia, but kind of like a deep/moderate sedation. They were not really versed in that, so they ended up doing a lot of surgeries with just kind of like morphine or just minimal sedation, not really a drip, which is like horrific. And it's not to blame the surgeons, obviously, because they went with the intention of helping, and that's a beautiful thing. But it's just a learning point for us in medicine that we need to coordinate these efforts better. And so really it is best to go under the umbrella of a medical aid organization, especially one that's experienced in that specific area, because they usually have stuff set up already. They have like a team down there. They usually work directly with local healthcare, like leadership, not just physicians, but even administrators, hospital administrators. And they usually have some kind of a pathway where you can integrate into the work rather than just showing up and being like, "Hey, I'll just do this thing." Um, so that should be clear now. So the lesson here was work to support the system on the ground, not to supplant it. So this is the major takeaway here. If you're interested in this kind of work, just one of my mentors used to always tell me, not in medicine, just other parts of life, he would say like don't have a savior complex. Don't ever have a savior complex when you come to help somebody, because it's not really the correct way to approach helping. Come as a supporter, not as a savior, because the savior complex is what causes you to kind of get your elbows out and be like, "Look, I'm a doctor," and then just start going rogue and doing stuff that actually may not be helpful, or may be minimally helpful and could be better if you had been a little bit more gentle and humble. So the lesson here, work to support the systems on the ground, or hope to support the systems if you're hoping to go into this work, not to supplant or replace them. There are physicians in these countries, there are medical personnel, there are administrators, there's a system there to integrate into. Um, so what are the strengths of emergency medicine in particular, our specialty? The first one that goes without saying, we have expertise beyond just traditional quote unquote medical knowledge. We have clinical knowledge that expands beyond that, right? So and every specialty does, but our knowledge is particularly conducive to conflict zones because we deal a lot in team leadership. We deal a lot in resource management, and especially at county, right? So we do this all the time. We have to be we never want to compromise patient care, but we just have to be aware of our resource management, right? Um, uh, we talk a good deal about MCI triage. The tag system, the red tag, the yellow tag, the black tag. This is super helpful in conflict zones because a lot of the times before they even get to, okay, definitive management like life-saving surgery, you have people who are just flocked in these emergency departments, that they're just overwhelmed, and they haven't even gone to the point of triaging them, because a lot of times they don't even have a triage mechanism existing any longer. Everybody's kind of just going rogue. And like I said, these emergency departments will also have like patients who are not there for medical support, but just there for shelter. So then you have to know how to triage. You can't just kind of just, um, go in with like a lack of you have to know how to prioritize. The pre-hospital care coordination that we do all the time. It's not just like the red phone, picking up the red phone, like, okay, we have pre-note. It's even beyond that. I mean, we don't do it a lot in New York City, but in rural areas, we know that physicians will deal directly with EMS on a number of issues, not just in pre-notifications. And for those who do the EMS rotation with FIDNY that we started this year, one of the days for the second years, or yeah, the second years haven't done it yet. One of the days you'll go to like one of FIDNY's headquarters in the Bronx, and you'll it's kind of cool. You'll sit down with a bunch of physicians who, a lot of them are ER physicians, who will receive calls from EMS, where EMS is basically asking them, giving them like a clinical scenario that's unfolding, and ask them, hey, I think it's AFib with RVR. I don't know if they're stable enough to transfer. Can I give DILT? Or they'll ask a clinical question like that. And so we have exposure to dealing with not just pre-hospital personnel, but also even exposure with different tools and resources for pre-hospital care. We have talks all the time on like hemorrhage control before the hospital and so many other talks. So this is definitely in our within our purview. Interdisciplinary coordination. This is one that we really underestimate. We're one of the few specialties that deals with so many other specialties directly, and not as like a consultant where you're like, look, ortho, like, I think the guy's injury is primarily orthopedic. Like, we don't want him. You guys should take him. Like, our interdisciplinary coordination is very different than that. We are in the middle dealing with different specialties at the same time, and not just because we want to dispo out of them. Sometimes because we want their opinion. Sometimes because we want to facilitate a procedure or facilitate an inpatient care or even facilitate outpatient care. How many times do you guys call an outpatient clinic or call the resident to ask for an appointment? So we do this a lot on a daily basis. Interfacility coordination, that goes without saying, right? Transfers and all that, or receiving transfers. Administrative insight. So we know that EM physicians tend to make up a good deal of the physician administrative staff. Those administrators who are physicians, a lot of them tend to be EM. Not all of them, obviously, but a lot of them do, because we have a unique insight into, like we said, interdisciplinary care and all the other stuff. Medical physicians with procedural competency. This is basically, we know we're not surgeons, right? And it's important to know that. Don't like go to an area like this and be like, hey, like I'm a procedural. Don't do that, right? I'm an emergency medicine physician. But we are medical physicians with procedural knowledge and procedural competency. So we can help with a moderate to deep sedation in situations where an anesthesiologist is not present. You should not ever market yourself as something you're not, though. You should never show up and be like, I could do anesthesia. You should say, I'm an emergency physician, I'm board certified in EM, but I can help with moderate sedation for this reduction or whatever it is. And the other strength, resourcefulness and adaptability, this goes without saying. I mean, the whole mantra of our residency is basically being adaptable, resourceful, flexible, and we always talk about resiliency, right? So that's a major strength for going to stressful places like conflict zones. So wrapping up here, what are some of the challenges? The big one, and this was even cited in the report after the Haiti earthquake, the biggest one would be pertinent medical knowledge. And it's not because we're not knowledgeable enough. It's because in crisis zones, the type of injury and the type of pathology differs from what we're used to. And it's important to recognize that, to be humble when you go into these areas, to know that I may see things that I'm not used to seeing. Not that we never learned about, because we discuss all these things, but I may not be used to seeing them. So the trauma is different. I mean, they obviously have the typical penetrating trauma, gunshot injury, stab wound, that kind of stuff that we've seen, but they have a lot of crush injury, which we don't see a lot of here in New York City. A lot of blast injury. That's also something we discuss a lot, but we don't see a lot of it. And so you just need to be aware of the limitations in your experience. And that shouldn't make you shy away from, participating in this stuff if this is something you've always been interested in, but it's just to be aware of your limitations. Also, the infectious disease is different. So we have the general training that is conducive to like adapting with new knowledge, how to do infectious disease in the ER, what kind of precautions to have, what kind of treatments are available, how do you prioritize the treatment, how do you prioritize individuals who are ill with a certain, but the type of pathogens differ, and so the diseases differ too. There may be things that we've kind of never discussed because like, oh, that's like a disease of the 1920s, we don't really see that anymore, but then you go to a conflict zone and you're seeing it all over the place. And then there may be things that we do discuss and we're aware of, but you'll just see more of it, like So, I mean, we don't have to go through this, right? Like Ebola, all the hemorrhagic fevers that we don't see, and so much more. And then the dispo is different. So a large part of our specialty here is based on disposition, and we're always trying to get a dispo, right? As we should. But this is a major difference. In crisis zones, a lot of times the dispo process is totally different. Sometimes you can't get a dispo. Like sometimes patients are actually going to be living in the ERs of some of these places because, like I said, a lot of people use it as a shelter. And so sometimes you're going to have to kind of be half ER doctor, half a little bit inpatient because you're not going to be able to be like, look, I know there's something going on, but it's not priority. They can follow up with outpatient provider. You can't really do that. There is no outpatient providers. So this is a situation where you have to, again, adjust your practice a little bit. But hopefully there would be other specialties on the ground in the ER with you that would also help. Um, and then the scope of practice. Um, this follows after dispo. Basically, we're used to kind of focusing on stabilizing and then dispositioning, but the scope of practice changes when you can't disposition as easily or you have to stay with the patient for days on end. So that changes. Another major limitation they noted was the limitation in the time of deployment. So unless you're kind of staffed with like a Doctors Without Borders, MSF, or one of those other organizations that will go and place you for like many weeks, a couple months at a time, and you're kind of doing it's like the transitional phase. You're just doing like a very quick, like 2 to 4 week trip, as a lot of physicians have done. A lot of ER physicians do. That is actually a challenge because a lot of times you're just the first 2 weeks you're just trying to get over the jet lag, just the psychological trauma of you coming into like a war zone. I mean, a lot of us have never even seen that in our lives, and hopefully we don't. But there's a lot of psychological adjustment that has to happen when you show up to a war zone, and then it goes without saying if you're in a situation where it's not as safe, and so you're going to spend a lot of time like maneuvering. And so by the time you adjust, I spoke with a lot of physicians who have gone just recently to Gaza, and this is one of the things they said. Like, by the time we adjusted, we were told our trip was over and we had to come back. And we were like, we just adjusted, like, we didn't feel like we did anything. And so that is something to consider. If you're really interested in this work, maybe go with an organization that will do a more longer course thing, like MSF, like a 6 week trip or like a 5 week trip. And so what are the takeaways here? The takeaways are that it is necessary work. It is within our purview of emergency medicine. Actually, not only is it within our purview, it also plays a lot of our strengths because a lot of ER doctors who go to these places end up doing more administrative work, and not administrative in the way that we think about it, but administrative in the sense that there's a lot of chaos and we're really good at organizing chaos. That's like what we do on a daily basis. And so you may not necessarily be going to do emergency medicine per se. You may be going to support the ER physicians already there in coordinating care in all other ways we already discussed. Uh, we would best serve ourselves in these situations by learning and understanding our rules. And these are just some resources, the WHO Academy and the WHO Red Book. This is pretty cool. It's totally free. It's online. You just make like a login and on the WHO website, and you can get this book that I've obviously not completed. It's like huge, but it's basically just like like all you need to know about going into different conflict zones and your role, not just for emergency medicine, but for all medical aid. And they obviously discuss emergency medicine, but it's for all medical aid. That's pretty much it.